Are you underdosing benzodiazepines for status epilepticus? How concerned should we be with benzodiazepine induced respiratory depression? What are the risks of subtherapeutic initial benzodiazepines for status epilepticus? Welcome, farmers and friends. Mark with PharmWise. I'm a board certified emergency medicine pharmacist that makes clinical pharmacotherapy content on the social medias. Infographics, patient cases, reels, shorts, YouTube videos, and podcasts made for learners of all medicine backgrounds. Thanks for joining me on the Code Blue Debrief, a clinical pharmacotherapy YouTube and podcast series. The focus of our episode today is going to be on benzodiazepines and dosing in the treatment of status epilepticus. Have you ever been caught in a dilemma, not a problem? A problem has one unfavorable option, while a dilemma has two unfavorable options. One of the more adult dilemmas I've had recently was the good old PGY2 residency ranking submissions. By the way, shout out to any 2019-2020 COVID resident that didn't early commit and had to go through the entire application and interview process. Back to my story here. I grew up more of a city beach boy from Torrance, California, but I've had my fair share of the greenery when it comes to the wilderness, trees, mountains, lakes in eastern Washington and northern Idaho during pharmacy school. As I was going through my top programs, location was a big thing for me. This would have been the third city I would have had to move to in 3 years, and I was just over picking up my things, starting a new life, and being at the bottom of the totem pole again with a new team. Program number one seemed a lot more appealing in terms of a city I wanted to move to, while program number two was a lot more naturey, and let's just say I was ready for a new experience. Another big consideration for me was obviously the learning experience. My decision came down to certain interactions that I had with preceptors at each respective presentation Q&A that I had. My presentation was on comparing succinylcholine and rocuronium for the use of rapid sequence intubation. Program number one had a certain preceptor that came in halfway through my presentation, asked me a "would you consider defasciculation dosing" question, laughs and scoffs at my answer, then doesn't even reply to my follow-up email. Program number two had a certain preceptor that asked what my considerations would have been for the use of succinylcholine in the setting of aspirin toxicity. It was more of a thought-provoking discussion rather than a yes or no answer. You can probably assume which program I ended up going with. When you're dealing with medications tailored towards specific patients, you're working on a spectrum of too little and undertreating, or too much and toxicities. You've got to work with the best available literature and evidence and make the best decision for the patient in front of you. Looks like you have a patient coming in with seizures via EMS. Let's review benzodiazepines in the treatment of status epilepticus. Status epilepticus is persistent, abnormal electrical brain activity that leads to neurologic ischemia and cellular brain damage. We need to terminate this seizure early and prevent this from turning into refractory status epilepticus. In simple terms, your brain's on overdrive with neurotransmitter hyperactivity. Our goal is to slow down the brain and prevent further neurologic ischemia. Guidelines recommend treating patients aggressively with benzodiazepines and other anticonvulsants. The focus of our discussion today is going to be on benzodiazepine dosing, but we'll tie in a key statistic for secondary anticonvulsants. It'll be good for us to review benzodiazepine dosing per the guideline recommendations. The initial treatment strategy is going to be addressing your ABCs, treating with abortive benzodiazepines, in addition to assessing and treating underlying etiologies. Benzodiazepines potentiate GABA, an inhibitory neurotransmitter, by binding to the receptor and allowing an influx of chloride. This results in a hyperpolarization of the cell membrane and reduces neuron firing. Per the 2016 American Epilepsy Society guidelines, benzodiazepines are dosed as follows. IM midazolam is given as 0.2 mg per kilogram with a max of 10 mg. IV lorazepam is dosed at 0.1 mg per kilogram with a max of 4 mg. And IV diazepam is given as 0.15 to 0.2 mg per kilogram with a max of 10 mg. Both IV lorazepam and diazepam may be repeated once. Even though trials have shown their safety and tolerability, studies consistently show that initial benzodiazepines are suboptimally dosed. Some studies show that initial benzodiazepines are underdosed in up to 95% of cases. Here's a statement from the guidelines regarding anticonvulsant adverse drug reactions. Respiratory and cardiac symptoms are the most common encountered treatment-emergent adverse events associated with IV anticonvulsant administration in adults with status epilepticus. The rate of respiratory depression in patients with status epilepticus treated with benzodiazepines is lower than in patients with status epilepticus treated with placebo, indicating that respiratory problems are an important consequence of untreated status epilepticus. Another thought to keep in mind with dosing is the etiology causing your seizures and anticipated intubations, such as an intracranial injury. As the medication expert, you need to know pharmacokinetics and the best medication to give based on access. Midazolam, lorazepam, and diazepam all have a rapid onset when given IV. The big thing to note here is the differences in their onset when given intramuscularly. Lorazepam has an onset of 20 minutes, while diazepam has an onset of 30 minutes when given IM. Compared to midazolam, it has a rapid onset, which would theoretically provide a faster onset and control of seizures. The half-lives for midazolam, lorazepam, and diazepam are 3 hours, 14 hours, and 60 hours respectively. Even though diazepam has a longer half-life than lorazepam, the latter appears to have a longer clinical benefit secondary to redistribution in the brain. The key here is identifying what access the patient has available. No IV access? Think midazolam IM. With IV access, you should be reaching for lorazepam IV. The sporadic and delayed absorption of lorazepam IM makes it unreliable compared to midazolam. The Rampart trial, or the intramuscular versus intravenous therapy for pre-hospital status epilepticus, was a double-blind, randomized, non-inferiority trial with 448 evaluated patients comparing pre-hospital intramuscular midazolam to intravenous lorazepam in status epilepticus for children and adults treated by paramedics. Intramuscular midazolam was dosed at 0.2 mg per kilogram with a max of 10 mg, while intravenous lorazepam was dosed at 0.1 mg per kilogram with a max of 4 mg. In their primary outcome of absence of seizures upon arrival to the ED, intramuscular midazolam was non-inferior to lorazepam. The seizure termination rate was 73.4% for IM midazolam compared to 63.4% for IV lorazepam. Keep in mind that this study was a non-inferiority trial. Overall, the endotracheal intubation rate was roughly 14% for both groups. That's after a single dose of the guideline recommendation. What kind of effect do you think a second dose of each benzodiazepine would do? The randomized trial of 3 anticonvulsants for status epilepticus, or the ESIT trial, was a study that showed that our secondary anticonvulsants of levetiracetam, fosphenytoin, and valproic acid have a similar safety profile and a seizure termination rate of around 50%. Let's discuss a study evaluating their benzodiazepine dosing, titled Underdosing of Benzodiazepines in Patients with Status Epilepticus, enrolled in the ESIT trial. This was a retrospective multi-center registry from the important ESIT trial. The authors of this specific study looked at their initial benzodiazepine dosing. The ESIT trial used a continuous variable of the initial and cumulative benzodiazepine dosing to meet their inclusion criteria. Patients could have received varying and multiple doses over time to meet that threshold. From their results, they showed that the initial dose of the first benzodiazepine was lower than the guideline recommendations in greater than 80% of midazolam cases and greater than 75% of lorazepam cases. It is difficult for us to understand the effectiveness of our anticonvulsants when we're underdosing our initial benzodiazepines. As I mentioned earlier, our secondary anticonvulsants have a termination rate of around 50%. I'll also throw in the fact that retrospective off-label use of lacosamide for status epilepticus have a similar termination rate. Maybe we should look at maximizing our initial benzodiazepines before looking into brivaracetam. Benzodiazepines are underdosed in up to 95% of cases when treating status epilepticus. Per guideline recommendations, benzodiazepines are dosed as follows: IM midazolam 0.2 milligrams per kilogram with a max of 10 milligrams. IV lorazepam 0.1 milligrams per kilogram with a max of 4 milligrams. And IV diazepam 0.15 to 0.2 milligrams per kilogram with a max of 10 milligrams. IV diazepam and lorazepam may be repeated once. Based on current practices, it appears that trial, one dose of initial benzodiazepines per guideline recommendations have a seizure termination rate closer to 70%. What are your thoughts on 2 doses of benzodiazepines before continuing to secondary anticonvulsants? Let me know in the comments below. Thanks for joining me on the Code Blue Debrief. Make sure to hit the like, subscribe, and notification bell. And make sure to follow my social medias for more clinical pharmacotherapy, infographics, reels, patient cases, and I hope you learned something new.